right, let's do this. Okay, so CBD and chronic non-cancer pain. What's the evidence? Does CBD alleviate pain, or does it not do anything at all, or does it exacerbate pain? Let's find out. So, first of all, I want to establish some context about false claims in the CBD industry. And there's a lot of them, like CBD cures cancer, CBD cures COVID. And hopefully, you know that those are false. Um, but there might be some more nuanced things that you're not aware of. So I got this article from Discover Magazine to hopefully supplement some of these false claims for you. So we'll start off really simple and just say that there's a huge distinction between cannabinoids and CBD as a monotherapy. Most of the time in research, CBD is used in conjunction with THC to look at pain outcomes. It's not used alone. And this is an important point because very often in this little article here, they will reference studies that look at THC and CBD mixtures, not CBD on its own, which is a huge problem, right? Because if we're thinking about whether CBD is a good analgesic or pain reliever, we need to examine it in isolation, not in conjunction with THC, in order to make those claims, right? So, just starting off, they say that quite a few clinical trials and researches, that is improper grammar, have indicated that the endocannabinoid system and cannabinoids can play a vital role in difficult to treat chronic and acute pain management. I wouldn't say vital, I would say very limited and often an adjunct sense. Also, again, it wouldn't be quite a few. It would be very, again, limited, and it would depend on the type of pain that you're talking about. You can't just say all chronic pain or all acute pain. It really depends on the type of pain. Are we talking about neuropathic pain, cancer pain, MS related pain, chronic back pain, fibromyalgia, right? There's a bunch of different things that we can think about when we talk about pain. So again, they cite more studies that show the incredible role that CBD can play in curbing pain and managing its intensity. So a 2018 animal model clinical trial, a report which was published in Frontiers in Pharmacology, has proven without a doubt, that's just unscientific language, that CBD is a great inhibitor of neuropathic, inflammatory, and cancer pain. And these are all artificially induced in mice to simulate the necessary conditions. Again, if we have really good evidence, why are you citing animal models? Why not cite randomized controlled trials in humans? I don't know. Maybe because we don't really have that good of evidence. So if we go further, in a 2016 review of several randomized controlled trials published in the Schmerz, it was suggested that cannabinoids can be a safe, efficient, and well-tolerated substance for these chronic pain conditions. Again, cannabinoids, not CBD as a monotherapy, which is very different, even though CBD is a cannabinoid. But if you actually read the paper that they cited, here's their conclusion. Currently, there is insufficient evidence for recommendation for any cannabinoid preparations for symptom management in patients with chronic pain associated with rheumatic diseases. In stark contrast to the claim on the left. All right, so let's keep moving. A 2020 review that looked at the role of CBD in chronic pain management, I actually cited this study in this presentation, has not been able to conclude with absolute certainty that non-pharmaceutical grade CBD can, in the absence of THC, do much to alleviate chronic pain among people. Here's the thing, it's never going to be conclusive with absolute certainty. There's always going to be an element of doubt in any endeavor in science. The fact that they're saying this really shows me that these people just don't take the time to either A, read the paper, or have a B, have a base knowledge of science before going on to cite these papers. And then our last little claim here is that pharmaceutical grade CBD, or what is more popularly known as medical marijuana, just quick caveat here, medical marijuana and pharmaceutical grade CBD. Medical marijuana is a more broader term. It encapsulates a lot of different things, including pharmaceutical grade CBD, but also things like nabiximols. You can have THC CBD combos. You can have THC alone. There's a lot of different ways that you can talk about medical marijuana. And then if you actually go to the study again, we see that none of the treatments had an effect greater than placebo on spontaneous or electrical pain responses, although more subjects receiving Bediol displayed a 30% decrease in pain scores compared to placebo. What this means is that A, Bediol is a THC CBD mixture. So again, this is not CBD as a monotherapy. And B, this is an acute study, so we can't say whether these effects are behave the same way in the long term. And a spoiler alert, they don't work as well in the long term as we'd like. So now we're going to move into some definitions. And I just want to say, this isn't meant to be anti-CBD. It's meant to be anti-misinformation. It may come off as anti-CBD, and that's because there isn't a lot of good evidence here. Like when you just look around, there aren't a lot of randomized controlled trials, and the ones we do have, they're full of bias. And they are the two that were conducted in 2003 and 2004. Right? So we need some more updated ones to come out. So some important definitions. Pain is an aversive sensory and emotional experience. It's typically caused by or resembling that caused by actual or potential tissue injury. The potential term is important here because it states that or implies that pain is more than just a biological phenomenon. It's born out of biological, psychological, and social factors, hence it's biopsychosocial. And you've probably heard that term thrown around, and I'll be throwing it around a lot more in this presentation. The next definition is chronic non-cancer pain. This is just moderate to severe pain lasting longer than 3 months, and obviously it excludes cancer and headache-related pain. Finally, our two cannabinoids that we're going to look at, CBD and THC. CBD is just the non-psychoactive cannabinoid, and THC is the main psychoactive cannabinoid. Both of these, they have different neurobiological mechanisms, and I'll go over the mechanisms later for CBD at the end of this presentation, but I really want the bulk of this presentation to just be about what the findings are currently with cannabinoids. We can touch on neurobiology a little bit later. If you have a background, that'll make it a lot easier to understand. If you don't, well, you might want to read up on neurobiology a little bit more before going into that segment, and that's at the very end of the presentation. So before we can talk about pain outcomes, we have to know how you measure pain. And generally in these studies, we're going to look at the top three pain measures. The McGill Pain Questionnaire isn't heavily used in cannabinoid research, although it has been used. I just won't cover that. And if you want info on that, you can just ask me and I'll give you the info. So first of all, pain is subjective, right? So we can only use subjective measures to evaluate our pain state. Objective measures like neurocorrelates of pain, they just don't exist yet. And they might exist in the future. I really doubt it because the pain experiences are so varied depending on the person, but who knows? They might come up with something. So our first pain measure is the visual analog scale. And this is just a continuum from no pain to pain as bad as it could possibly be. And basically you just mark where you are along that continuum. It's 100 millimeters in length. And what you do to get an objective measure of the subjective task is you basically measure in millimeters from the left end to the right to the mark. So the further along from the left end to the mark, the more pain you have. And then we move into something like the numerical rating scale. And this is unidimensional, just like the visual analog scale, and that means it only captures really one aspect of the pain experience. And it is a little bit easier to comply with compared to the visual analog scale because it can be used in verbal and written administration, although it's not as sensitive to change as the visual analog scale because it only has 11 points at which you can change your pain score from 0 to 10 versus the VAS where it's basically infinite if you really think about it. Those are the two main measures in subjective pain. And then when we take a look at neuropathic pain, right? So that this scale does not require diagnosis of neuropathic pain. It's graded on a 0 to 10 scale along many dimensions. So good, it's multidimensional, meaning it's capturing multiple aspects of this pain experience. And these could be things like very hot, very cold, very sharp, things that are typically associated with neuropathic pain. Moving on to animals. So first, when we look at animals, we're usually talking about rats. And then when we look at rats and CBD research, there's good potential here. Like I'm not gonna lie, there is good potential, but we need to see human studies to see if these effects actually play out in a way that's clinically beneficial and clinically meaningful. So the difference between rats and humans is pretty stark. But in terms of CBD, right? So two main things going on here. Rats can have either a higher bioavailability of CBD, or they can just use CBD in different routes of administration in the studies. And that would be something like an intraperitoneal injection. I don't think anyone's ever injected CBD, and I don't think you should, but if you have, let me know because that's actually pretty interesting. So what higher bioavailability basically means is that if rats and humans are given equated doses of CBD, rats will have more CBD in the bloodstream to use for things like analgesic effects, anxiolytic effects, etc. But then if we actually move into the pain outcomes here, and I'll explain these bolded terms as we go. So we move into these pain outcomes. We can first see that in a rat model of diabetes, if CBD is given early on, you'll see a decrease in tactile allodynia and thermal hyperalgesia in these rat models. And what these two terms mean is independently is that allodynia is you're attributing pain to something that normally doesn't cause pain. So if I touched a desk and I suddenly had a sharp jolt of pain, that would be a form of allodynia, albeit a very rare form of allodynia. And if you have something like thermal hyperalgesia, that means you're super sensitive to heat stimuli and you experience pain very readily from those things. If we move into something like rat models of neuropathic inflammatory pain, we can see that the CBD decreases pain in these models compared to placebo. And then if we move into something like topical CBD, which is completely different and hasn't been studied as much as the CBD industry claims, right? So CBD can decrease inflammation and increase paw withdrawal latency in rats as well. And topical, again, is just applied on the skin. And what paw withdrawal latency is basically your time to remove your hand from a painful stimulus. So if I put my hand on a hot stove and removed it very quickly, I could say that I experienced a lot of pain. But if I put my hand on a hot stove and I removed it less quickly, then I experienced less pain. And that's our best bet in terms of getting a behavioral measure of pain that we're going to see in rats, because it's very difficult for rats to communicate their subjective experience of pain to humans, as you could well imagine. And then if we look at like humans, like what about us, right? Well, it's pretty depressing. So first of all, there's just not a lot of human randomized controlled trials, which is our best level of evidence for evaluating the efficacy of an analgesic such as CBD. So Wait et al. Found a beneficial acute, so 2 weeks response of oromucosal CBD on pain outcomes using the visual analog scale, but that was not confirmed by NotCut at all. And both of these studies were at high risk of bias because they just didn't have a lot of people doing it. So It's easy to get outliers here. So we see contradictory information with our 2 randomized controlled trials, so we don't know what to say. And then we move into our next best alternative, which is nabiximols, and these could be either Sativex or Nabidiolex, and I'll let you look at the ratios below, but they're basically both 1-to-1 ratios of THC to CBD. And these will provide mild acute pain relief. And mild means less than 1 point on the visual analog scale. And when you think about that, that's not a lot. And that is basically 100 millimeters in length, and you go down 1 millimeter. It's just really not clinically significant at all. And there are, again, some limitations here. One is that when CBD or nabiximols, when they're used in these studies, they're used as adjunct therapies, meaning they're used in conjunction with other therapies, or they could be used after a person has failed out of a particular therapy, whether that be opioids or cognitive behavioral therapy, and so on. Also, there is no approved CBD product for pain management. There is one for epilepsy, and it's called Epidiolex, which basically treats 2 rare and severe forms of epilepsy. But beyond that, there's really nothing. These are all short-term studies. There's little long-term follow-up. There are also vastly different pain states. So you can look at neuropathic and chronic back pain in the same study, even though they have vastly different mechanisms, which is kind of strange, but that's what we have to do. We have to pool results when we don't have enough of one study to examine a effect. The dosages are also just, they're not firmly established at all. We don't know what CBD doses are good for people in certain types of pain. And again, oral CBD and inhalation has been studied the most. Topical CBD hasn't really been studied that much. And I haven't seen a study that's used topical CBD in humans. But if you have, let me know. But most of these randomized controlled trials, or all of them, are using oral CBD. Or oral nabiximols, which is a problem for those in the CBD industry who are claiming that topical CBD can alleviate pain. Now, if we expand our view a little bit and we look at cannabinoids and chronic musculoskeletal pain, we can see some interesting things. First of all, when we look at the level of evidence, right, we can see that most of the time there's level 4 and level 5 evidence that's going to dominate. And level 4 and level 5 evidence is mainly uncontrolled case reports and observational data. So pretty poor data because it's not controlling for placebo and social effects going on. And what we can see is that some standouts, there's a low level of evidence in general for chronic back pain. These are all, there is no randomized controlled trials. And like I said, level 4 and level 5 evidence will dominate. These studies also point towards effectiveness, but they cautiously do so because, again, these are very biased because of these uncontrolled studies. So we need better data, period. And then if we expand our view once more and look at all aspects of pain and cannabinoids, so this includes cancer pain now, we can see we have 3 good systematic reviews or meta-analyses here going over cannabinoids and pain. And the results aren't that promising. I take favor to the left-hand systematic review and meta-analysis the most. Whiting et al., I didn't particularly enjoy because they didn't put their effects in context of a clinically significant pain response. Allan et al. Was okay because they talked about bias a lot, but they needed to do a better job of examining some of these adverse effects. So let's start on the left. What these abbreviations mean is number needed to benefit and number needed to harm. So this is the number of patients you'd have to give the CBD or cannabinoids to get a beneficial pain response. So you have to give 24 people cannabinoids before you get a beneficial pain response. but you only have to give 6 people cannabinoids if you want to get a harmful response, which is telling, right? Because the risk to reward ratio here is very high in favor of risk. And also, when we look at the amount of pain decrease in these studies, it's only a 3 millimeter decrease compared to placebo. And that's not great on the visual analog scale. Again, because if we look at this 100 millimeter scale and we see that maybe placebo decreased pain by 20 millimeters and cannabinoids decreased pain by 23 millimeters, is that 3 millimeter difference really significant or clinically significant? Probably not. I believe the authors of that paper said that a 30 millimeter or 50 millimeter decrease in pain would be moderately or majorly significant for a pain decrease. But 3 millimeters, no, I don't think so. And again, these studies are looking at neuropathic and MS related pain most of the time. So you can't really say that these effects will go or generalize to chronic back pain or fibromyalgia. You really can't say that because these are different pain states. Finally, as treatment time increases for these cannabinoids, the reported benefit of them in terms of pain decreases. So these really only act well or as they're supposed to in the acute term. We can't say that for the long term. Then when we look at Whiting et al., we see that they only looked at neuropathic and cancer pain randomized controlled trials. They found a moderate positive effect on pain. There was also high risk of adverse effects, such as dizziness, vomiting, and balance and hallucination. And then finally, our last little systematic review, they found very small positive effects for cannabinoids, but they were uncertain about these effects because of the high risk of bias of these studies. We just need better studies to control for these things, and we need them to be at higher sample sizes to see whether these effects are really due to cannabinoids or whether they're due to outliers. We also see, contrary to popular belief, some drawbacks and risks of CBD. So in epileptic patients who are taking Epidiolex, right, we can see that they have drowsiness, less appetite, diarrhea, and elevated liver function. There could be potential adverse interactions with other drugs, although CBD has been used in conjunction with fentanyl and it hasn't been shown to produce any harmful effects. We still need more data to see whether that's the case for other drugs or not. I also know that there is some research to suggest that patients given cannabinoids show a decrease in the amount of opioids they're taking, which could be beneficial, right? But if the pain response isn't that decreased because of cannabinoid use, then I don't know if it could be that beneficial anymore. Finally, we could also look at the topical route of administration. It hasn't really been studied. Like I said, oral has been studied the most, so we need more data on topical before we can really accept these CBD industry claims. Finally, when we look at the non-FDA approved CBD products, which is basically everything except the Epidiolex, we can see that they contain higher amounts of THC. They might be laced with synthetic cannabinoids, which could lead to hospitalizations. And there's also just inaccurate labeling of CBD concentrations going on here. There's also benefits, right? There's benefits. It treats 2 rare and severe forms of epilepsy, which doesn't have anything to do with pain, but why not? It's a benefit, right? There's also something called the entourage effect, and this is where THC and CBD administered together produce a more beneficial response than THC alone or CBD alone. And this is simply because there's more data for THC CBD mixtures than there is for THC in isolation or CBD in isolation. Also, Vukovic said that CBD can lower the risk of developing psychotic illness related to cannabis use. And we also see good long-term safety with CBD, and we can see that It has potential as an adjunct therapy for chronic non-cancer pain, anxiety, and inflammatory conditions, but we need a bunch more research to change that potential into actuality. And then when we get to placebo, nocebo, and social effects, these are really important because CBD is frequently touted as a cure-all. It's touted as a chronic pain reliever, and these can have significant placebo effects in the population and might steer people away from better treatments, or it might steer people towards nocebo effects as well. So what these are basically is that placebo effect is that if you believe that a treatment is going to work, it has a higher likelihood of working. If you believe a treatment is going to harm you or not work, then it has a higher likelihood of not working. And these effects are important because it's really hard to distinguish in observational studies or anecdote between CBD or placebo or confounders in the study. And then when we look at social effects like social learning, we can just say that the more time people spend around those taking CBD or talking about CBD alleviating pain or people in pain, the more likely those people are to experience those same things. And all these factors, again, will steer people towards worse treatments. It will steer people away from better treatments, or it just might nocebo them. Like if a person says, well, if you go off CBD, then you're going to experience pain, right? Then that person is at a higher likelihood of experiencing pain. And at the end of the day, pain is complicated. You can have nociception occurring without pain. You can have different pain conditions clumped together in studies, as we talked about before. And we have to understand that pain is a perception, not a sensation. It's an interpretation. It's a bodily and psychological interpretation of an environmental input. And that doesn't mean that pain is all in your head, because there are conscious mechanisms to alleviate pain, but there are also unconscious mechanisms, and the unconscious mechanisms usually dominate. But it does mean that if we understand pain, we might be able to have a better influence on it than we could otherwise. So just to wrap up and review before I move on to the neurobiology, CBD and chronic non-cancer pain, we need a lot more high quality research before we can make the claims that are being made in the CBD industry. Most CBD products are simply unreliable. You got to talk to your doctor if they're even willing to say, go out and try it. If you're looking for a CBD product and you don't know where to turn, Harrison et al. In the references is a good place to start in terms of thinking about what products might cause less adverse effects compared to others. And finally, as said, pain is not all in your head, but you do have some psychological leverage over it. And then there was the neurobiology. So getting to this is a monster, first of all. And if you don't understand this, you don't need to stick around. You looked at the important claims. This is more like me nerding out because I like it. So let's just start with the first line and talk about the entourage effect. We said that THC and CBD administered together is better, but why is that the case? So if we look at the diagram below, I'll explain this to the best of my ability. So first of all, on the left, me circling, this is a nociceptor. So this is a nociceptive neuron. On the left-hand side, we have a painful stimulus that's basically stimulating this nociceptor, and this will generate an action potential that will release neurotransmitter from the axon terminal over to the postsynaptic dendrite. And once it gets to the postsynaptic dendrite, this is where the action potential travels along this neuron, and then it'll go up to the CNS and communicate a pain response. So basically what you need to know is that an action potential that's generated in this postsynaptic dendrite, that will likely lead to a pain response. Although it might not, as I said, nociception is not always related to pain. And then when we get to THC and CBD, we have to understand something about the CB1 receptor. Unlike other receptors, the CB1 receptor is a presynaptic receptor. Most or all other receptors are postsynaptic. What this means is that when THC binds to the CB1 receptor, THC will create a very strong CB1 receptor activation. And when it does so, it decreases neurotransmitter release from this axon terminal to the postsynaptic dendrite. And because it decreases neurotransmitter release, we can say that there will be less of an action potential in the postsynaptic dendrite, so there's less of a pain response communicated to the brain. The problem with this is that THC is so potent at the CB1 receptor that you honestly might have some adverse effects come along with the THC. And what CBD does so well is that it acts as a negative allosteric modulator for CB1. Basically, it decreases the activity a little bit of the CB1 receptor to keep the positive effects from THC, but also decrease the negative effects that come with the positive analgesic effects. So that is why THC and CBD is better. And then there are a bunch of other mechanisms, right? So we can talk about CBD as a TRPV1 agonist. CBD is in green, by the way. So when CBD binds to TRPV1, it's going to just decrease the analgesic effects. Increase the analgesic effects or decrease the hyperalgesic effects of TRPV1. TRPV1 is a receptor that's normally sensitive and to capsaicin, which is found in peppers. When capsaicin binds to TRPV1, you usually get a painful response. The reason why CBD works well at decreasing pain when it binds to TRPV1 is that it does so in a way that decreases the sensitivity of TRPV1 to other stimuli. Because CBD decreases the sensitivity, it just decreases the frequency of action potentials that are generated in that postsynaptic dendrite. And then when we look at anandamide reuptake, this is another interesting thing. So anandamide is an endogenous cannabinoid, meaning it's found within the body, and it acts very similar to THC, namely that it binds to CB1 receptors. When anandamide binds to CB1 receptors, you're going to get that exact same thing happening. You get a decrease in neurotransmitter release, and you just get less amounts of action potentials. So what CBD does really well is it prevents anandamide from going back into the postsynaptic dendrite to be recycled and broken down by fatty acid amide hydrolase. And because there's more anandamide in the synapse, it more readily binds to CB1 to get those analgesic effects going. Finally, when we look at CBD binding to 5-HT1A receptors, that's the serotonin receptor that's normally involved in pain modulation. CBD acts as an agonist at the 5-HT1A receptor. When it acts as an agonist here, 5-HT1A receptors are inhibitory G protein coupled receptors, meaning that when these guys are excited, you simply get an influx of negative ions into this dendrite, and that will decrease the likelihood of experiencing an action potential because you're getting hyperpolarization of that dendrite instead of depolarization. So all in all, what CBD does really well is that through all these mechanisms, in some way, it decreases the amount of action potentials going to the CNS to communicate the pain response. And that is the basic neurobiology for potential analgesic mechanisms of CBD. Here are all the references. I believe there's 24. And Harrison et al. Is number 6. So if you want to check that out, looking at a clinician's guide to cannabidiol and hemp oils, go ahead and do so. But that is it for me. Thank you for listening. And if you've found value in this, please share this with others. Okay, and we're